Welcome to part 2 of our feature on the psychologization of chronic illness, specifically long COVID and ME/CFS. In this film, we'll be covering the tricky topic of sticking up for yourself in the face of healthcare providers trying to tell you that it's all in your head. If you saw part 1, you'll remember the story from Dr Kelly Fernley. Well, here's some evidence she's shared with us of distinctly non-psychological symptoms. Cyanosis of the feet, a rare but acknowledged symptom of long COVID. And here also a textbook demonstration of POTS, with already tachycardic heart rate of around 100 whilst lying on her back, quickly turning into a scarily high 130s just from the act of standing up. Most likely anxiety, according to the senior registrar who saw her on her most recent hospital visit. Right. Okay, let's crack on with the discussion.
How did we get to a position where you have psychiatrists and psychologists leading trials on biomedical illness? So, for example, you wouldn't have a psychiatrist or a psychologist leading research into treatments for chronic obstructive pulmonary disease or ischemic heart disease. Yet, despite all the autoimmune and autonomic abnormalities that one encounters in ME/CFS, long COVID, fibromyalgia, long Lyme, EDS, MCAS, still very much the prevalent narrative is that this is psychological. The people leading the treatments are psychiatrists and psychologists, and they continue to do this despite mounting biomedical evidence. So in the long COVID clinics, for example, if you talk to the patients, the approach that is taken is very much one of psychological support and rehab, rather than actually, this is a new illness. Let's do some biomedical investigation. Let's be humble about it. Let's get some symptomatic treatment. How have we enabled this?
Well, I think to some extent, it's history repeating itself in rapid form right in front of our eyes. So the idea that a lot of the symptoms that we see in COVID and in long COVID are actually quite internal. At the outset of the pandemic, we were all looking for, persistent coughs and high temperatures and things like this. But as the experience rolled on, we found that actually the most common symptoms were things that are harder to measure, harder to see from the outside. And straight away, medical science kind of had difficulties readjusting to acknowledge that the symptoms were actually quite subjective in many cases in terms of the measurement methods needed. And we had this trap effect so that the physical versions with the high temperatures and the persistent coughs were seen as real, and the other ones were seen as less trustworthy. But there's also a realpolitik around the reaction of professions, because professions aren't dispassionate and objective all the time. And many of the people who were, I suppose, heavily invested in the psychogenic or cognitive behavior therapy approach to ME/CFS appear to now have become very heavily invested in directing these therapies to long COVID. And it's not uncontroversial because, of course, the treatments for ME/CFS that are prescribed in the UK by NICE have been extremely controversial, have been extremely problematic. The research underlying them has been effectively debunked. And to be fair, NICE itself seems to be changing its position, and having declared the research to be unreliable is now changing its recommendations, as we would anticipate based on their draft guideline. So there's a real effect here in terms of professional politics, where a large subset of clinicians feel perhaps threatened by the changing sort of landscape and see long COVID as an opportunity. And I don't want to get into areas where we might be accused of defaming individuals, but it could be summarized as in terms of a relatively small number of leading professionals, thought leaders, influencers, if you like, in the psychology professions and psychiatry professions, people who are public figures in their own right, who have leaned into this narrative for long COVID. And it's hard to separate the possibility that the reason they're doing this is because of professional self-interest. It's a new market, it's a new opportunity. And there are entanglements with insurance companies and just the reality of public funded psychological services maybe having to be shut down or curtailed because of changing NICE guidelines. Why wouldn't you, if you're heavily invested in providing this type of therapy, why wouldn't you look at long COVID as an opportunity?
I was just going to make a quick observation that I think being in this situation where these ideas about what is essentially the wrong management or mismanagement of patients with ME/CFS and that being extrapolated to patients with long COVID, I mean, it puts you in a very vulnerable position as a patient. And what I think is actually kind of ingrained in mainstream medicine, unfortunately, is this kind of word association between chronic fatigue and graded exercise therapy and CBT, which is inappropriate. But it's now, certainly I feel like I'm coming against this kind of wall of that I have to kind of get over with any clinician that I'm facing to try to kind of re-educate them, I suppose, while being ill myself. And I think, and it does put you in such a kind of exposed and vulnerable position, and adds to that feeling of not being believed, where you are, you know, a patient and you're trying to say, well, actually this person in this eminent position, or this professor, whoever they are, who's espousing this management, they're wrong and I'm right. And it's very challenging. It's very challenging to do it while you're sick. And I think it's challenging for me as a doctor to do this. Who knows how challenging it must be for the average patient. But I would add to that I have learned a huge amount from the ME/CFS community. Probably the most helpful thing, actually, to me in my recovery that I've made so far. So I'm very grateful for that.
I absolutely, from like almost day one, so that's 500 odd days ago now, realized I had a professional and social responsibility to get the message out about this new disease and then this other new disease that afflicted me. And that does weigh heavily, because you're not well. It's difficult. You can't always, of course, with this damn thing, get the words out properly. And the precision of vocabulary and speech in science and medicine is so very important. But I do feel that.
Yeah, so I suppose I was thinking about, you know, one of the other issues which links back to the idea we've talked about of doctors not wanting to admit they don't know, is there's also a kind of, I suppose, having to accept, you know, that medical science is not infallible, that knowledge and evidence evolves. And I think, you know, this again is where we see history repeating itself with long COVID, is that if as a doctor, you know, you have come out of medical school believing that ME/CFS is a psychological disorder, if you've spent years telling every ME/CFS patient that it's all in their head and referring them for graded exercise therapy, then with new evidence and new guidelines and all the rest of it, you not only have to unlearn everything that you thought you knew, but you also have to kind of, I suppose, look back at all of those patients you've treated and accept that you have potentially caused harm to them, not meaning to necessarily, but that you have caused harm to those patients. And so I think there's a real kind of cognitive dissonance there with doctors kind of clinging to what they've always known and the way they've always done it, because actually it's really difficult to unlearn that and to have to accept that you might have inadvertently harmed people in the past.
I can see it in a really positive way, actually. I think we've reached a bit of a fork in the road, and it's full of opportunity. So on one branch, we go back into old ways, we repeat old narratives. We follow a very small, select but powerful group of psychiatrists who have a monopoly on this sector, or we use the opportunities of health inequalities, greater public awareness of minority groups, greater public awareness of the patient expert and the patient voice in driving things, and also the opportunity of long COVID being a new disease and having that ability to say, for professionals to save face and say, I don't know, this is new, I've never seen it before. So it is an opportunity for us to admit that we don't know and to try and move on together. And with all these things coming at once, there is a way of forward, from my perspective, to empower the patients, the thousands, the tens of thousands, the hundreds of thousands of patients who all have the same narrative, in taking down that old psychological one that maybe was fit for purpose 20 years ago, but isn't anymore.
Yeah, I suppose what we're talking about here is the classic paradigm shift situation, a sort of a scientific revolution, and people have, philosophy of science has looked at this over the years, and has tried to describe their circumstances, and it does look like the circumstances that lead to a paradigm shift. There's a build-up of kind of uncertainty around established ideas that create what are known as a sort of a scientific crisis. But all scientific revolutions, are controversial, and they're resisted for the reasons that have been discussed previously. And sometimes it just takes time. And sometimes, Max Planck said that, science changes its mind sort of one funeral at a time. You're waiting for the old geezers to, leave the stage so that the new generation can kind of, have the opportunity to look at new ideas. It's hard for people to change minds, exactly as just has been described. There's a whole cognitive dissonance piece to it, and there are real barriers to that. So in a sense, I see this as a great opportunity for change, but change isn't guaranteed. We didn't refer to the royal free outbreak from the 1950s, which was described initially as myalgic encephalomyelitis. And that was in the media. That was a massive news story. Hundreds of people in the Royal Free Hospital fell ill. There was no explanation. It was presumed, therefore, to be a neurological condition. But 15 years later, the medical profession came back on it. And the British Medical Journal published a new analysis by authors who never visited the hospital or spoke to any of the patients, but who concluded that actually it was a case of mass hysteria. And they even used the term myalgia nervosa. They suggested that would be a better name for this condition, myalgic encephalomyelitis, because it is the terminology we use to describe women's illnesses, like anorexia nervosa. So it's another case of a psychologically driven condition. And after 15 years so this was a massive news story, but history was rewritten by the establishment subsequently. So we might have confidence about long COVID now, but if we don't push the issue, if we don't encourage new thinking, and we don't empower new science and new voices, the old voices will come back and they will fight their corner, and they may actually carry the day, because people, they want to move on. They want to go back to where we were before the whole COVID pandemic. People have a natural inclination to kind of look the other way rather than deal with controversies head on.
Yeah, thank you. We're running on a little bit, so I'm going to ask one question for everybody to pipe in if they've got an answer for it. But it would be, what is the one thing that patients can do if they are faced with some degree of psychologization of their condition from their healthcare provider?
I think the problem is most patients in the acute sort of setting or the clinical interaction are so blindsided by the suggestion that they're making it up. They don't really respond. They're too ill to really get their heads around what the doctor is actually saying to them. It's only when they leave the appointment that they reflect on it and they think that doctor didn't really get what I was saying. And as the doctor, because I've sat on both sides of the table, as the doctor, you think you did quite well. What should happen is the patient, once they've reflected on it, should have some way of feeding back to that doctor, because they didn't. The doctor actually thinks they were quite holistic, thoughtful, compassionate, but nevertheless disbelieving. And that is a point at which meeting in the middle is not good enough. The doctor has to fully be on the patient's side for this to move forward.
Totally. And I think maybe we as doctor patients who are possibly over the worst bit of our illness or have reached some point of stability, even if we're sick, are in a privileged position to do that. And I'm sure it's no secret that the entry criterion for your COVID recovery 2 is doing a 1-minute sit to stand, which, certainly in my case, and a lot of other patients' cases, puts me in bed for days. So I have been advising people on our support group to decline harmful therapies. Inform yourselves with the science, because there's plenty of guidance out there now, CDC guidance, World Physio paper, and then actually refuse harmful treatments and feed that back. We should be able to do that.
Yeah, so I mean, I think, as Nina says, it's very difficult when you are in that situation, to necessarily be able to advocate for yourself in the moment. I think that's something where, there's almost sometimes kind of an unrealistic expectation that patients will argue back or, stand up for themselves or dispute something, which doesn't recognize that there is a power imbalance in that doctor-patient relationship. And there were some comments made by Nadine Dorries, which I hugely objected to in October when the APPG on endometriosis published their report. And the government, still have not committed to the recommendations that were in that report. But her comments were, something along the lines of, women should not allow themselves to be fobbed off. And so I really object to this idea, actually, that the onus should be on the patient to get the care that they deserve. And I'm always very careful in my work to, try and balance the advice that I give with a reminder that actually, if you've received bad care, that is not your fault. It's not on you. That said, I think things like taking somebody with you who is more able to advocate for yourself, for you than you are yourself, can be really useful. As Nina says, giving feedback afterwards, going back to the doctor, perhaps with something written down so you feel a bit more prepared, and saying, actually, last time you said this, this, and this. I've gone away, I've done my research, this is what I disagree with, this is how you made me feel. That can be really useful, and not being afraid to ask for a second opinion, which I think a lot of patients just don't realize is an option. That there's kind of this idea still that doctor knows best and you have to just take them at their word, and that isn't the case. It should be a collaboration, that your doctor should be working with you to find the solutions. So those are kind of the things that I always say, particularly to the women that I work with, but with that caveat that it's not your fault if that doesn't help.
Very good advice. Thank you.
The closest I think I've come to this was an interesting situation. They just shown a video of me on BBC Wales one evening in a program on long COVID, and then they interviewed a non-medic in charge of services at my local health board, and I was a bit brain foggy that night. So Nina and Sarah's points are utterly sort of appropriate about you may not have your wits about you, and it would be a good idea to take a friend whose brain is working fully and quickly. And anyway, so this woman came on, and she's a physiotherapist with a PhD, and I don't think she'd ever seen a patient with long COVID, and she comes out with a comment, and I'm thinking this isn't very good, and my wife instantly sat up and started shouting at the television, and almost threw her phone at it. And I was thinking, no, she's obviously said something that's not very good. And the phrase that was used was, oh, these poor things, all they need is a bit of rehab and they'll be on the mend. And it took me a good couple of minutes to get angry. It was quite interesting that all my circuits were a bit slow that night. But yeah, you have to be sympathetic that people may not be in a fit state to give you an answer. It's like coming around from an anaesthetic and you can hear the anaesthetist saying, Ian, and you think, there's a little voice here somewhere, where am I? It's all black. You know, and you can't, you want to respond, but you can't. It's a question of kindness, isn't it? Listening to people, starting from the premise that they're being honest, they're telling you the truth.
Yes, I just wanted to sort of come back and just clarify that I wasn't saying the responsibility is on the patient, but what I was saying was that we have probably got a duty to empower patients with knowledge and the language to push back against the harmful therapies. But I agree, it's really hard, even being medical, when you're that sick.
Great. I think Asad and I are probably fairly cooked at this point. I don't know if Nina, you're a bit cooked as well. So thank you so much, everybody, for taking the time out of your mornings. I think this is hugely helpful and is going to find a very appreciative audience amongst both long COVID and ME/CFS communities. I hope you found that discussion helpful, and going forwards, hopefully, we will start to see attitudes begin to change. Next up, we'll be speaking to consultant neurologist Dr Hadi Manji about the impact of long COVID on the nervous system. Going to be a good one. Till next time.